remind him of the microphone.
Good afternoon. Welcome. Hi, everybody. It's a real pleasure to have you join us here at the Harn Museum of Art this afternoon. I'm Director of Education here. My name is Eric Siegel, and it's a pleasure to have the opportunity to moderate this panel, speak with our panelists, who I will introduce momentarily, a very esteemed group. I want to make sure to mention that after the discussion today, and there will be time for questions to be sure, so discussion, questions, so definitely think about the issues that you find pressing and of deep interest that you'd like to follow up on, and get ready to ask those. There will be a reception after, and we invite you to join us for that. I do want to make sure to mention that. It has and is an honor to host this exhibition of work by J. Frederick May, Jeff, here near the end of the table. Jeff, you can wave. Just demonstrating some of his abilities after the stroke movement. To host this exhibition of his work, I find it really compelling, and it was exciting to install it and to see it here in this room. You'll all have a chance to look at it afterwards on your own. It can be haunting and a little bit paranoid at times, I think, to look at this work. I'd love to hear what Jeff thinks about that.
That's a good description.
Great, paranoid. We'll still stand with that. But one of the things I really find fascinating is that although we all know the brain is involved in vision, and we're going to have the opportunity to think about that more today with our neurologist panelists, we don't experience the brain, I think, as involved in vision. We think that we see through I am seeing you through my eyes, right? It's my eyes that I feel like I'm seeing you through. But when we look at these works, we begin to feel that sort of resistance, that you have to struggle to see, and you're working to reconstruct and to try and figure out how things, so you become aware of vision and of the brain's role in that. That's one of the powerful things about these works. There's the simultaneous feeling of, thank God that every day I don't have to do this, that I do experience normal vision, right? And the realization that there's a whole lot of processes going on there that you aren't aware of. And it also makes you wonder, if these are hallucinations or representations of hallucinations that Jeff experienced with vision subject to damage after a stroke, what are the sort of hallucinations that we may be experiencing? How is our reality transformed by brains? I'd love if we get to touch on these kinds of issues that are evoked by the works, I think, as we look at them. And those comments I want to just share, just one work by M.C. Escher, who is a similar artist, a very different artist, but whose work also asks us to question perception and to put together how we see the world and how our brain is involved in that. So he creates these amazing worlds that are really based on rationality, whereas Jeff's images have this sort of ghost-like quality to them. A little different, but sharing, I think, one kind of theme. We didn't talk about that yet, but I'd love to hear your response there as well. So without further ado, I'd like to introduce our panelists ever so briefly. Jill Sankey at the far end is director of the Center for Arts and Medicine here at UF. She is a leader of the center. She's a faculty there and an affiliate faculty of several departments here on campus, and works very interdisciplinarily. She is an expert in dance and often brings that to medical and other areas of inquiry here on campus. Dr. Heilman is from Brooklyn. There's a few more things to say about him, but he is from Brooklyn, and he's also an eminent neurologist and professor emeritus at UF. His life work has included numerous breakthrough discoveries about the architecture of the brain in relation to perception and to bodily movement. Dr. Adam Kelly is an associate professor of neurology at UF College of Medicine. He takes a keen interest in improving the quality of care for stroke patients, and he works on acute stroke patient treatment and on prevention as well. Dr. Polifka, I don't believe is from Brooklyn, is assistant professor of neurosurgery at UF College of Medicine. He has specialized training in vascular disorders and neurovascular systems, and specialized interest in spinal disorders and reconstruction. So we're 2/3 of the way down the table. Jeff May is an artist and a former photojournalist, and we'll have a chance to talk to him more momentarily. And Lisa Hammert is Jeff May's manager, his wife, and a former journalist yourself. Exactly. So we'll have a chance to discuss all of them. I neglected to close the doors. Can I ask you to do that just to cut out the sound in the back? Thank you. Appreciate that. So I thought we would begin by just talking with Jeff a little bit about his experience. I mentioned a moment ago that he was a photojournalist for many years. He worked internationally as a photographer and as a filmmaker in a style very different from what we know. And I'd love to hear a little bit about what your work was as a photojournalist and a filmmaker, and how you saw your visual expressions.
Mm-hmm. As a photojournalist, I was a newspaper photojournalist, so I worked mostly for newspapers. I did do a lot of freelance work as well for magazines. But ending that career in 2000, Lisa and I went on and formed a production company, and we did industrial film work for nonprofits, municipalities, educational institutions, and we established a pretty good reputation in that area. The one thing about that is, and being a photojournalist, I had learned to become what is called a one-man band. Okay, I could pull broadcast sound, I could do cinematography, I could edit, I'm like a one-man band guy, and I can do all that, or I could. Let's put it that way. And I could do it fast. We used to even joke about 5 minutes or less sometimes. And actually, there was an assignment I did one time where I went to a person's house and had to talk my way in to get a photograph and be out in 5 minutes or less. They didn't even know I was going. But that was no longer possible.
Right.
And I found that the hard way. Yeah.
Right. So, and Adam, I think, knows your background pretty well, and you can add on, please, as we fill it in. But in 2012, you were undergoing open heart surgery?
Yes. I had an ascending aortic aneurysm. If you don't know what that is, that's where your aorta leaves the heart, the valve at the heart, and goes to the tree, which is here, and it's the size of a garden hose. And they put a piece of Dacron tubing in there, which, when they put it in, then theoretically the aorta grows over that eventually, I guess. And that during that procedure, allegedly I had a stroke. Yeah. I wasn't aware of it, and I wasn't aware of it till the next morning when I just knew that I wasn't seeing quite right. And because I don't see a black demarcation of blindness. And I don't really even identify with blind so much as I identify with brain injury, because I always seem fine. I feel like I can see just fine, and that's the big deception, and that's where I get into trouble.
Right. You said allegedly. You're still a little bit suspicious of this diagnosis. You said allegedly had a stroke.
Oh yeah, that's when I had. Well, I did have a stroke. Yeah,
but you didn't.
I was. I was saying we weren't sure when it was. Is what I meant.
Yeah. Okay.
Yeah.
And Lisa, so what did you see that next day and thereafter as Jeff saw himself as not being impacted particularly by the events of the 2012 stroke?
Well, it is a gift. It ended up being a gift, but I didn't see it that way the next morning. The next morning when I walked in, the nurse said, "We've had a different morning." And that different morning was, he can't see his hand from like right here on. And he had been an image maker his entire life. And he seemed okay, like I can see, I can move all of my body parts, I'm fine. And the first thing he said, which stunned me, was he said, "Well, why not me?" Wow, that's kind of big.
No, I mean, it's true. You're in
Why not me?
5%, window.
Mm-hmm.
And I kind of followed him.
So why
from
not
there.
me unaffected?
Yeah, why not?
Why shouldn't it be perfectly normal after?
No.
I meant like, why don't I just? I
Why
can get a
not?
stroke as much as anybody else, Why not?
Okay.
It's
Yeah.
just something I never considered, I wasn't even a thought really going in, but I had the stroke, and to be really honest, when they tell you, oh, you've had a stroke and you just, got out of major, thoracic surgery, I'm going, I feel really good. I just survived those things. Let's get out of here. I bet.
So the work we're looking at here in the auditorium comes. So you had another stroke in 2015, but between the two strokes, you began to experience hallucinations, which
Yes.
this work is responding to. Is that correct?
That's correct, yes. And these hallucinations that you see here started while I was in the hospital. And that's hence the name ICU, which is just kind of a play on words. But they did begin there, and they begin, as you see these, the dark areas that make up the face, or the dark areas, they just suggest a face. They're not actually a face, they just suggest it. And those are what I saw, and those were animated in that they danced around in a very crude animation trying to assemble themselves. And if you try to look at them directly, they disappear, they just go away. But then they kind of like just come back, they just flow back in on their own eventually if you give it time. And I probably experienced those for the first 18 months mainly, and then they dissipated on their own, and I picked up a different group of very peripheral groups of people as hallucinations. And I still have those today, so.
Yeah, if you don't mind, I'd like to take a moment just to show this approximation you created of that sense of the hallucinations as you experienced them.
A crude, it runs a little fast. I'm sorry, it runs a little fast, but that's basically how they would be. They share the same parts, and they move around between each other. So they're trying to assemble and make it correct, and it just never quite makes it. And then it falls away, usually. And that's what I noticed, and I had told Lisa while I was in the hospital, she would walk me around the ward at Cedars-Sinai, and I would tell her what was going on over here on the right side, like a running monologue of events happening that she had no idea were going on. And I had told her, I said, don't tell anybody, I'm seeing this stuff, they're going to keep me here forever. And, but she ratted me out immediately to Dr. Song, and then they explained the whole thing, and it was very good, so it was not a problem.
Great.
Yeah.
So I'd love to take a pause for a moment.
Sure.
And so since we're in the hospital and you've been through open heart surgery and you've experienced a stroke, I'd like to turn to the doctors and get some other a response from them about what they're hearing, how this sounds, the kinds of experience of hallucinations, if this makes sense, or if we are particularly concerned about you at this moment. So what do you see, or what do you hear when Jeff talks about coming out of the surgery, recovering the next day, and feeling perfectly normal, or relatively normal, considering the experience, and what you as doctors might see?
Sure. I can say a few things, and then I'll pass it along to Dr. Polifka as well. I think just a couple things. I think, any neurologic change that someone has, especially if it comes on all of a sudden, is potentially concerning for a stroke. When we were talking the other day about, things that, that would be important for the panel to discuss, I think, and Jeff has even mentioned this, that he doesn't maybe fit the stereotype of what a lot of people think of when they envision someone who's had a stroke, and that he didn't experience weakness, he didn't experience changes with his speech, he didn't, experience some other of the typical again, stereotypes that we have of stroke patients. But still, I think the fact that his symptoms came on all of a sudden and did involve some neurologic functions, I think it certainly is concerning for a stroke, and I think it was appropriate that he was worked up as such. I think it's also important that, what you described, which wasn't that you had this black piece of missing vision, that's pretty typical for brain-related problems affecting vision. If you have something in your eye, you'll be more apt to see, okay, I have a black spot in my vision. But, most commonly when people have vision problems, in the cortex of the brain where vision is actually processed, they may or may not know that there's a vision problem there, but it won't be this big, gap or divide there. So I don't know if you want to add anything, or maybe comment on the surgical issues and how strokes might happen after surgery and why that might have happened in his case.
So, my role primarily in stroke is taking care of acute stroke. If someone presents quick enough, we're able to go into the blood vessels and actually remove the blood clot and reverse the stroke. And so in Jeff's case, he had something called a embolic phenomenon, so a piece of clot developed on the inside of the artery and went up to a very specific area of his brain. Those strokes can be actually strokes that we can reverse sometimes, but in Jeff's case, it was something where he became aware of it much too late for it to be reversible. And it really kind of illustrates our need to have heightened awareness about stroke, that too often we think of someone having a stroke as they're completely unable to speak or they're totally paralyzed in one side of their body. But people can be having a stroke and have symptoms that are much less obvious. And they may seem, talking to someone, they may seem totally normal, but in the reality is they can be having a major stroke. I think that's one of the important things, is to really heighten our awareness that if something isn't normal and it happens out of the blue, that we should suspect that a stroke is happening.
I've got a question just in regards to that. Is there any way under anesthesia that are there any physical changes that say that a stroke has actually occurred?
So there can be, there's a lot of surgery that I do where we do specific monitoring to look for that. Unfortunately, for Jeff's case, to look for a stroke that goes to the occipital lobe and affecting our vision centers, we can't detect that. So we can detect changes in the sensory and motor systems acutely, and do something to try and change them. But check the occipital lobe, we can't do that acutely. We really need, the only way to know about it is to have the patient awake and says,
I can't see.
Seeing, right?
Yeah.
The other thing I want to add, and then just while we're talking about stroke awareness and recognition of stroke symptoms, and Dr. Polifka, I think touched on this, but I think it's important, we always want to get this message out anytime we're doing any kind of public awareness about stroke, is really the importance of time. Stroke symptoms, again, Jeff's case is unique in that it happened during surgery, but that's not how the vast majority of strokes are going to occur. And when we do have options that we can offer for intervention, they're very, very time sensitive. So, whenever there are stroke symptoms, these are not the things where you say, let me sleep this off, and if it's not better, then I'll get that checked out in the morning. By that time, our options, if we have any, are going to be very, very limited. So I think, we have hospital systems that are set up, to deliver care as quickly as we can, but we have to have people recognize those symptoms, call 911, get to the hospital. So I think if there's one thing, hopefully, that people leave from the standpoint of stroke awareness, it's the importance of time.
Could I add something to that?
Yes, please do.
And just to reiterate that, as a person who, in 2015, I was very educated about my stroke I had previously had, and when I had my 2015 stroke, I completely disregarded every warning sign there was. Everyone, and they even had Lisa drive me to the hospital, and which was just ridiculous. I should just dial 911.
Right.
The whole stroke team was like, "What? You drove in?" Yeah.
Yes, I really appreciate the thoughts about awareness. I want to talk also about your specific condition, Jeff, and then also a little bit about treatment and how it has evolved. But Dr. Heilman, I'd love to ask you a little bit about, so it's Charles Bonnet syndrome, Jeff, that you were diagnosed with. And Dr. Heilman, I'd love to ask you to help us understand what that is and how it relates to the brain. And I also have your slides.
Okay.
Well,
let me get started. And I hate to pick on neurosurgeons, but, neurologists, we do that. And
Let's keep it nice.
and people, other people also, Brooklyn comes out every once in a while. It turns out that when people have hallucinations, of course, in general, the most common cause is psychiatric disease. People with schizophrenia, for example, have hallucinations. Now, what's really interesting about that is, for the most part, those hallucinations are auditory. And when you hear about a visual hallucination, it is almost always neurological. So that's an important point. The second point is that the most common cause of hallucinations is not stroke. It turns out to be epilepsy and seizures. And as we talked earlier, there's a long history of people who actually described a very similar disorder. I gave Jeff a paper last
Great
night.
reading.
Great reading.
It was written by a neurologist, Monroe Cole, who had a very similar experience, and he described this going all the way back to the late 1800s, when it was described earlier. So you can have visual hallucinations with stroke, but we don't really know how common it is, okay? Now, when you see hallucinations in general, the question comes up, what's going on? What is a hallucination? And why do people have it? So all of us have imagery. So if I say to you, imagine a map of Florida, okay? So many of you, when you imagine a map of Florida, okay, and I say, well, tell me, do you think it's further from here to Pensacola or from here to Miami? A lot of people, what they'll do is close their eyes so that they can image, okay, so they can see the map and look at those comparisons. So in some way, okay, we can see things in our mind. One is through imagery, and one is hallucinations. So why would a stroke cause hallucinations, and what's happening there? Well, it turns out that in some way, if I can give you an example that I talked about last night, think of our ability to perceive what we're seeing or imaging like a television screen. And this television screen has two inputs. One's like a camera, and the camera is like your eyes. The other one is a videotape or some other recording device, and that goes in there. Now, what happens for survival benefit, you always want the camera to take precedence over the videotape machine, okay? But they're always going. So what happens is, if your camera breaks down, there appears images on your television from the tape machine, okay? And that's pretty much what happens. Why does it happen? Why does it happen? Just very briefly, we have two hemispheres, a right and a left. And it turns out that in many things we do, the two hemispheres have to be able to communicate, okay? So if you put this in my left hand with my eyes closed and ask me what it is, okay, I feel it, but to give you the name pencil, I have to get the information that's coming from my arm into my right hemisphere to cross over to my left so I can say pencil, okay? Now, it turns out that the two hemispheres also have different functions. And that is a blessing, because what that allows us to do is parallel processing. One hemisphere is doing some stuff we can talk about later, and the other hemisphere is doing other things, okay? So what happens is each hemisphere has to also inhibit the other hemisphere, saying, hey, wait, this is my job, don't you do it. Hey, this is my job, don't you do it. It turns out he damages one hemisphere, his left hemisphere. It can no longer tell the right hemisphere, hey, wait a minute, this is my job. So the right hemisphere becomes active. And it turns out, as we talked about last night, the place in the brain that stores images of faces is in the right occipital lobe. And so he freed it, it became disinhibited, and he was imaging those things that he saw.
Thank you so much. That's fascinating. And now I feel like it's okay to multitask, right? Right brain, left brain, we can do it all. Jeff and Lisa, we've talked a little bit about that you see your work as part of your recovery, right?
Yes.
That it's had a therapeutic role for
Yes.
you. And I'd love to hear more about that from you, and also to talk with our panelists, the doctors, and to Jill about how they've seen what I would think of as non-conventional treatments or activities as productive for recovering from stroke and other kinds of brain injuries. So if you could start, Jeff, by talking about how your work has helped you recover.
Yes, and the work you see here really wasn't realized until after my 2015 stroke. It had been created, but I didn't realize it till then when I saw it as a body of work, and it was quite large. And I was like, wow, this is, and then I was able to trace it down to my hallucinations. But as being part of my therapy, as I found out, was in bringing to fruition the shows, I was told that if you can use, the more faculties you can use in solving a problem, the more plasticity you can achieve. So I went, well, if I can take it from a digital concept to a construction, three-dimensional piece, that would be the best I could do, because you're using your hands and your eyes, everything. You're making mistakes, you're correcting the mistakes, so that's the premise I used for it. And I'm good at that. I'm good at taking something and making it into something else. So after my 2015 evaluation, I was able to kind of retool my working process from a production company, which at the time Lisa and I were, to an artist practice. And it was a daunting task in the sense that we did it in a really short amount of time, and it's kept us very busy. But I also brought it upon myself, and probably too much so, to make every show different that I did, but based on the concept of a construction. And I wanted to have a construction feel. And in fact, and this is another, we talked about subconscious and things. If you look at the marks I make on my prints, it wasn't until recently I realized that they're the construction marks I see on the roads. And it's actually prevalent in another show of watercolor, but they're actually construction marks that I see down when I walk, when I have the infamous jogger that goes by. And so I obviously pull a lot of subconscious into it, and I'm not even aware of it, and I'm only becoming aware of it now. So does that make?
Yeah, that's great. Thank you. So, and I'm just going to point of clarification, then Dr. Heilman. So there were two strokes. So 2012 is where you began to experience these mobile hallucinations that are approximated here.
Yes.
By 2015, you weren't seeing those.
No,
But that was a second stroke, leaving you with different kind of visual disorders.
It left with me with different deficits.
Great.
And that's when I had an evaluation done to just see what the baseline on those deficits were, in case I incurred any other thing, which could be anything from Alzheimer's to another stroke. And I learned a great deal about where my weaknesses were that I had no idea, where I just felt, if I just keep banging my head against this, I'm going to get the right answer, Mm-hmm. And it just, it was just so enlightening, to where I even thought back, wow, if I'd had this evaluation when I was like 18, I would have thought about you could solve a lot of problems.
Thank you. Dr. Heilman, you had a response to the question about therapies.
I wanted to say something. As I mentioned to him last evening, when people develop a disability, And somebody like Jeff actually goes ahead, and that allows him to actually enhance the quality of his productivity in his life. He's a hero. Now, probably turns out that that woman sitting next to him plays a huge role.
Yes, indeed.
I'd like to talk about something that we didn't mention much about last night, and that is that there's another part of the brain that's very, very important in creativity, and that's the frontal lobes. The frontal lobes allows us to disengage. So, for example, Copernicus, who came up with the concept that the sun is the center of the solar system. Back then, before him, it was always the Earth. And they had to have these Ptolemaic theories that were very complicated to explain it. And he said, wait a minute. Hey, this doesn't make sense. Okay? And that is called disengagement. They disengage from what they've been doing, and they think about other ways of doing it, okay, in general. Now, unfortunately, sometimes that can get you into problem. Let me see, there was this Italian guy who proved it, and the Pope condemned him for the rest of his life. But didn't they forgive him in 1996? No? Galileo. He was forgiven for proving a thing. So he also had the concept of divergent thinking. Now, after you have disengagement, you have divergent thinking. And that is also a frontal lobe function. And fortunately, even though he damaged his left occipital lobe, his frontal lobes were still functioning, and functioning very well. So not only did he have divergent thinking, but he had the power and motivation to go ahead and turn those things into works of art. And there is nothing more difficult than being an artist. Okay? Artists have the most difficult time. They don't get paid much. They don't get recognized much. And in order to be a successful artist, you have to have a very well-developed frontal lobe. When Einstein died, they did a post-mortem and looked at his brain. The largest part of his brain was his right frontal lobe. So, Jeff, I hate to compliment you. I'd rather insult him like I insult other people.
Those are very kind words. Thank you.
You have a wonderful and creative frontal lobe.
Well, thank you so much. You're very gracious.
Thank you, Dr. Hyland. Doctors Adam and Kelly and Plifka, excuse me. Are you Doctors Adams?
Yeah.
Your thoughts about non-conventional or alternative kinds of extra medical treatments, such as creativity or brain challenges?
I think the one thing I think Jeff you mentioned is this concept of plasticity, which is a term that we use, and I think to not oversimplify things, but basically when there is any kind of damage to the brain, especially we'll use stroke as an example here, the brain doesn't regrow itself like a salamander's tail. I mean, that part of the brain will always be damaged, and so what we have to try to do during stroke recovery is have other parts of the brain make new connections and sort of quote unquote make up for what the damaged or injured part was doing. And probably the best way to do that is to immerse yourself, to really, to expose yourself to, stimulation, whether it be visual or in the case of something physical, maybe dance, something that really stimulates these areas to form new connections. And so I don't think, I'm not a rehab specialist per se, but it's obviously a big part of what we all do. I don't think there's a one-size-fits-all approach to rehab. I think it's, what are your symptoms, what are some things that you enjoy doing that you want to engage in as part of a rehab process, and hopefully that will help form these new connections. Unfortunately, I think there's a lot that we don't understand about brain recovery and why some people are able to make these new connections and have a different stroke recovery or different brain recovery than someone else. I think we'd love to be able to facilitate that plasticity even more than we currently are, but hopefully in the future we'll be able to.
Thank you, Adam.
I've got just a question on that. Does the person's past, meaning, his 10,000 images, as we were talking yesterday, how much does that matter? What they did before, does that play a part? How big?
Yeah, I mean, we talked about that a little bit last night. I think it's a little bit of a, and just so you know, we keep mentioning last night, we had more of a panel for medical providers last night. There was a lot of overlap between what we're talking about today. I think, and as we spoke about on the phone too, I think it's a little bit of a double-edged sword. I think in some sense, because you were so visually oriented prior to this, I think, you may have been more sensitive to some things that maybe someone else wouldn't have been. So I'll give another example, in the spirit of arts. And we've all probably seen a lot of people who are musicians who, develop strokes where maybe they develop problems with fine motor control that maybe the average person would be able to compensate for just fine, but it's going to affect them differently. Or a surgeon, who's very technical with his or her hands. On the flip side, I think it also, it probably, those areas are also somewhat well developed already, so maybe it leads you to pursue these strategies that help those areas form new connections too. So I think that's, I guess one way that I would think about conceptualizing it.
Yeah, it turns out that if you look who comes with Alzheimer's disease, and the people who are the most educated are the ones that are least likely to come down with Alzheimer's. And we don't really know exactly, but the general rule with this and all kinds of brain damage is that if you have a reservoir and you lose water, like brain damage, the deeper the reservoir, the more water you still have. So if you are very educated, you're active, and so forth, no matter what happens to the brain, you will have less of a disability than somebody who's less educated or does less active things with their mind.
So this event today is a prophylactic for us. We're all building that reservoir up.
I don't know. After sitting next to Adam for 2 days now, I don't.
Dr. Polifka, did you have a thought?
I think another important piece that we are now becoming more and more aware about, again, going back to Jeff mentioning plasticity, is that, and also how he had mentioned he associates more with people who have brain injury as opposed to people with strokes, and the one commonality that the two have is the concept of rehabilitation and how our ideas about rehabilitation have completely changed. And I would actually think that what Jeff has done with his career is probably the best rehab that he could do in terms of a very focused rehabilitation. And that's really our goals in terms of brain rehab now, is really assessing what are people's deficits and coming up with very targeted therapy to help with that brain plasticity, to help them overcome their deficits and help them rewire their brain. So that, I think, your change in career path has probably been perhaps your best rehab.
That's absolutely fascinating. So, Jill, now that you've been distracted, we can call on you. So what's your response? No, I wasn't going to ask you to respond to something yet. I wanted to just get your thoughts on, or your experience working with patients with various movement disorders, possibly stroke patients, and how your work from the perspective of arts and medicines intersects here.
Sure. I'd like to pick up on a couple of comments that I think are very interesting in relation to the discipline of arts and health. Both the comment about, or Jeff's comment about bringing multiple faculties to bear in rehabilitation, and then Dr. Kelly's comment on helping people find what they enjoy to engage in rehabilitation. And I think those ideas represent a component of the field of discipline of health, of arts and health, and the ways in which the arts are providing opportunities for those things. We have, for example, in our programs, representative of the field, a number of programs in partnership, in fact, with the Department of Neurology. We've got a program that we've been running since 2009, Dance for Life, which is a dance program for people with Parkinson's disease, and that's complemented by weekly programs for people with PD and movement disorders focused on both drawing and singing. We also have an artist in residence who works at Vista, our rehabilitation center, and he's doing particularly interesting work there in that he's working in partnership with the clinicians there. So the clinicians who are seeing particular deficits and also recognizing particular interests among their patients are able to invite the artist in as a partner to say, hey, let's use music. How can we engage music with this patient for particular purposes? So we have artists in every discipline available in our hospital. We have visual artists, writers, musicians, dancers, dramatists, so that people's interests can be brought to bear. And for instance, our folks with Parkinson's disease are able to, they have 4 opportunities a week here in Gainesville to engage creatively, to be coming together socially, to be challenging themselves physically, cognitively, creatively. We just started a new program for people with MS as well, a dance program. And what I love about these programs is it's, as has been alluded to, another option. So for many people, rehabilitation can be very focused and very effective if it's, kind of more like traditional physical therapy, which is goal-oriented, goals each day, goals each week. But for many people, that sort of motivation isn't the best approach. So if you have an opportunity to be a part of a drama troupe where you're coming forward verbally, physically, creatively, part of a dance group where, again, you're challenged by rhythm, range of motion, balance, strength, creativity, and motivated by things like music and imagery and narrative, the idea that I can express this idea through my movement may be a different kind of opportunity than can I do this movement 10 times today. So again, the arts are coming to bear now in healthcare as another option and another opportunity in a really powerful way to engage people in a very broad, holistic way in achieving their goals. And I love as well the partnerships that are developing. Dr. Heilman will remember when we first started doing this here at UF Health 30 years ago. It was kind of like...
That was the year before she was born.
And I remember being at tables with you years and years ago and thinking, gosh, is he going to even take this seriously? I felt so, sort of self-conscious about being just an artist at a table of, clinicians thinking about what we could do for our patients. And Dr. Heilman was one who, of course, has a deep understanding of the arts and creativity. But I think this discipline has evolved over time now, where artists are now part of interdisciplinary care teams, and there's a really gorgeous understanding that these opportunities are really important and really effective. And of course, now we've got great research that helps us understand that a little bit more deeply. So I love, Jeff, the example of your work, and I know your experience came not from an arts and health program, but really came from an organic place of you finding tools and resources that were natural and available to you.
Well, yes, that's absolutely all. That's great.
Thank you. Dr. Heilman, and then I'm going to be turning to the audience to invite your questions as well.
No, I want to say something because I think Jill said something very, very important. And that is, with a lot of brain damage or any kind of disability, there's very commonly depression associated with it. And depression in general is not healthy for rehabilitation because depression diminishes motivation. I can go on, and you look almost forward to death rather than to life and living. One of the beautiful things about art, and any type of creativity, actually, I first realized this is when we did an experiment and we got these very exciting the results. And I said to a person I was doing with, Bob Watson, boy, this is one of the most exciting things that I've ever seen. And he looked at me, he was a resident, and he said, boy, Dr. Howman, you're really weird. And I said, that's true, but why you say it? He said, well, because you said looking at this data and seeing the results really is exciting and made you really happy. It turns out that in our brain, deep in our brain, there's a little area. And originally, what they discovered this was actually in rats. They put an electrode down deep into the brain, and every time the rat pressed a little pedal, a shock went down and stimulated that little area. The little rat enjoyed it so much that they would even stop to eat. Okay? That's how much joy it gave him. It turns out that we think now, when people have or do something creative, that same area deep in the brain is excited. Okay? And what's more important for rehabilitation and quality of life than looking forward because you have learned to enjoy something rather than looking back, being depressed and saying, hey, I want it to end. So creativity is an invitation to life, and that's why it is so important. And people like Jill are inviting people to life.
Thank you for those wonderful comments. Really pressed my area. Again, I would love to invite questions from all of you here in attendance of any of our panelists, the doctors, Jill, Jeff, and Lisa.
Ask me anything.
Jeff, I haven't had the opportunity to read the information about the art, but I'm wondering how you produce it. I know technology has not come so far for you to be able to put a camera inside your head.
Yes, that's very true.
But you are reproducing, I presume, accurately what you are seeing so that we can see it. How does this work?
What I started out, and this started out in 2012 on an iPad 1, one of the original iPad 1s, and I just call it riffing on imagery is what I call it, where I just do, all those great apps, you can do anything to them. And I was always interested in glitch software, where it literally corrupts the code and you get a damaged photograph out of it. Kind of like the way Brain was always a great parallel to the Brain, I thought. So I started working with a few programs, and I created quite a bit of imagery. And it wasn't until I saw it in 2015, after I had an evaluation, that I saw it as a body of work, as part of my rehabilitation. It was very subconscious. And that's when I embraced it. Now, how the process is actually done is the glitch, that's kind of a whole different thing, how you make it in a glitch program, because it would be unfair to say you could just put any image into the glitch program and it comes out like this. What is involved in that aspect of it is influencing the algorithms. And that's done by just saving the images that you like as a setting. So then your tastes are figured into the algorithm, your aesthetic choices. And so there may be 52 algorithms that are already in it that are doing random havoc on the image, but you can put yours, the more you can influence. And I would also do it to where I would erase the settings. So it would have to be new every time. I had to get back to a point. And anyway, I accumulated a lot of imagery. And like for each one you see, I probably created 300 or 400 and saved 60 or 30, a very small amount for consideration. And there's a huge, number of just that are worthless images. And from that point, I had to make it into for myself, I wanted to make it into a photographic image, because it really isn't. It's just a digital piece that's on an iPad that probably started out as either a mugshot from a long time ago or a photo booth image. That's what, and Lisa and I collect a lot of Inferior stuff like that. So that's where they started out, and I just really didn't want them to look like anything else. The goal was not to recognize what it was. I wanted it to be an entity that was a question. It wasn't male, it wasn't female. It could be, what is it? I don't know what's going on. Is it a ghost? What is it? It's just very a question. I didn't want people to identify with like a celebrity, like did you glitch somebody's image or whatever. So that was my main goal with that. At that point, to get it off the iPad as a image, I decided to go with a cyanotype process. Cyanotype is what's also known as a sun print or an iron print. And it's a very simple process. You coat a piece of watercolor paper, you make a negative, like I would take my digital images, I make a digital negative. It's about this big, and then I contact print that as a cyanotype. And then it comes out all blue, like a blueprint, because that's what they are. And it's the same type of process. So at that point, I would then bleach that blue cyanotype, and it would, I bleach it with washing soda, and then I would dye them with tea or stain them with tea. And that gives the background. It goes to the neutral color then, which is really the ground of the photograph, as in the ground of a painting. Because it's really, if you look particularly at the Verna one over there,
So that would be the second one.
Yeah, the second one over.
On the big wall.
You'll notice that your perception of what is there, it has nothing to do with the face. There's two dots, there's a little thing, and then there's just some lips, and the rest of it is open space. There's nothing there, but it implies a line, and you kind of put it together in your head, and that was kind of my goal with it. And it's kind of your brain does the rest of the putting it together. And it's that's I find that kind of interesting. My work now, it seems to photograph on. I say I get lost.
Work seems to photograph. Where were you?
Not photograph. It's really based on seeing and memory and perception. And I like the place where the errors occur in that little equation. That's what I'm interested in. Does that make sense how I did it? So the cyanotype, that's where I left off. These are scans from cyanotypes, is what they are. And then I print these myself. And so the cyanotypes are saved as a plate, and we keep those, so they're safe. But these started out as original cyanotypes.
Sir.
Yes, during your hallucination, did you hear any sound?
I have one sound hallucination. I don't know if it's tinnitus, though. It may be tinnitus. It sounds like sometimes when it's very quiet, I hear an industrial engine. It's like the soundtrack. Have you ever seen Eraserhead? It's the soundtrack to Eraserhead in my head. And I thought it was the water heater for a long time. And then it was like, no, that's in my head. So I don't know what that means, but it does sound boom, boom.
I'm not sure either.
Don't know. I was counting on you guys.
I think, based on, what we know about your CAT scans and MRI scans, which we talked about a little bit last night, I don't know that we have the best explanation for why that would happen. I think Dr. Heilman talked about like where your stroke occurred and what that would do to, your visual areas. I mean, I think what we would call our primary auditory cortex is a distinct area from that. So it may be something.
I thought it was tonight. It might be tonight.
It might be, yeah.
But that's the only auditory I experience. Yes. Colors. I do. The hallucinations I have now are colorful. And they came later on as a group of people that congregate on my right when my brain is really tired. And it'll be like after this tonight when we get back to the hotel room, I'll be really tired. And if I just sit there quietly, they will kind of start congregating over here. And they kind of move around. There's a lot of color. I can't see. They're just not paying attention to me at all. They're just there doing their own thing. And they could be anything from, I think they're like Mardi Gras band members one time with these pink and they have those pink and orange like band suits on, but they didn't have any instruments. They were just kind of loitering, just hanging out. And then there's I have skateboarders and BMX bike kids that kind of just roll in. They just stand there and then they disappear if you look at them, and they would come and go. They kind of come in waves of different ones. And I do get one also, and I figured this one out. I think I've got this. See what you think about this. With my iPad, I've had a number of times. The only times I've actually been startled or scared by the apparitions or the hallucination would be when I'm holding my iPad late at night. Now, if I'm sitting there holding it, all of a sudden a hand will come in and grab it. But I figured out it's my own hand. Because what it is my hand on this side is not in my memory because I don't see it. So all of a sudden it's startled by my own hand and it invents one. And that's cool. So things like that I do for entertainment.
Mr. Mays, I hope you do have an opportunity to sleep.
I do.
And when you do, are your dreams have hallucinations?
No, not so much. My dreams, I will be very honest with you, are generally what I call aggravation mares. They're not about nightmares or anything like that. They're generally about aggravation, and usually associated with my previous work in photojournalism. That's what they're about. They're usually about that I've gone to 3 different places without film and have to go back to the bureau and pick this up, and they're like that. I don't have anything like this. Yeah. They're very just like the annoying ones most people have.
We have a question in the back of the room.
Yeah, question. You mentioned hallucinations involving crowds of people. Anything involving fantastic creatures or?
No, not for me. I only can speak from my experience. Nothing. It was all very human in suggestion, anyway. Yes.
And the one thing, there's we used the term before, something called Charles Bonnet syndrome, which are these hallucinations that come about when people have damage to their visual areas. By convention, and Dr. Howman, you can chime in too, and Adam, if you've had experience with this, they're usually non-threatening. They're not usually, frightening or are meant to be threatening in any way. And why that is, I'm not sure we really know, but that's the classic. That's what we're taught anyway.
I've never felt threatened by them. Maybe there people are, but I know people are scared by the fact that they have the hallucination, right. And in a lot of cases, never say anything because they think people will think they're crazy. And
earlier I said when people have psychoses, most of their scary hallucinations are scary, but they're for the most part auditory. And visual hallucinations are very rarely scary, other than having them, but not what they're visualizing. That's correct.
We have time for probably just another question.
So are these hallucinations kind of grounded in spatial? Like, are they kind of contextualized, or do they just like?
Yes, these faces, as you see here, started in the very beginning, and they would animate about in this area,
okay,
right?
So they aggregate around.
Right here, as I talk to you, there would be a face forming and talking and trying to do something and distract me the whole time while I was there, and it would just keep changing and mean something else and coming back and going away, and so the trick was you then become obsessed with trying to see it, because if you look at it, it's gone. Okay, so that's kind of the It's really exciting at our house.
Well, we've come to the end of our panel time, but we do have reception time to follow. I was negligent in the beginning, forgetting to thank all the sponsors who made this possible. Of course, we're grateful to our colleagues from the University of Florida Department of Neurology, but the program was supported by the Creative Bee program of the University of Florida. Center for Arts and Medicine, of course, is a major collaborator. UF Health, the Center for Movement Disorders and Neuro Restoration has been crucial. So we're delighted that UF has come together in this collaborative spirit to make this exhibition and program happen. And again, the collaborators here today, Dr. Heilman, Dr. Adams, Dr. Kelly, and Dr. Polifka, and Jill Sankey, we're grateful to them. Please join me in thanking them all for this great panel. And of course, we're grateful to Lisa and Jeff for traveling here to be with us today. And I can tell there's a lot more questions for our panelists, and we invite you to join us in the reception to talk further amongst yourselves and with our panelists just outside of the Galleria.
If anybody wants to ask me a question.